So good morning, ladies and gentlemen. So it's on to a clinician now for the real world experience. And you'll see how sometimes it's difficult, sometimes we have ethical dilemmas ourselves, but hopefully everybody will learn from this. So I'm very passionate and always have been passionate about the inclusion of pregnant women in trials. So 50% of our population are women, so that's the starting point. And what I'm going to do is take you really on a little bit of a journey from where I started and where we are now. So during the talk, I will go over the importance, I think, of inclusion of pregnant women in trials, what trials we've been doing in Ireland, the eMERGE trial, and how that posed ethical dilemmas. This is a trial we've just completed. And then looking at perceptions and experiences of women who partook in the eMERGE trial and the understanding of informed consent, because we all do informed consent, but really I was interested to know, was our process of informed consent actually consenting patients properly? So including pregnant women in clinical trials is really important because it's needed really to advance and inform healthcare. And when we do that, we get better treatments. And when we have better treatments, we have healthier mothers and infants in the pregnancy. And healthy mothers in pregnancy leads to healthier families and improves really the health of the nation. And if you extend that out, improves global health. Participation in international trials by pregnant women in Ireland is also important because it allows those women to access new medicines and new technologies earlier before other people. We all know that healthcare is usually superior in locations that are conducting clinical trials. So if you're in that frame of doing trials, doing things properly, it lifts the healthcare for the whole population that you're looking after. And trial results can inform both national and international guidelines, which is important. However, if you look at 2017, only 0.32% of registered trials were pregnancy drug trials. So up until 2017, at least, very little was happening. So I've always been involved in pregnant women in trials and observational studies and using real-world data. And in 2006, the HRB funded me to establish the Atlantic Diabetes and Pregnancy Programme. And that was to look at all aspects of diabetes care, diabetes outcomes, what we were doing right, what we needed to improve on. And these women, over the last 20 years, in the Sales Hospital Group, have contributed to this programme endlessly. So I've pointed out here just some of the areas that they've contributed to, which is improving the process of healthcare, how we screen people, how we follow people up, the importance of making the diagnosis because of future risk of diabetes, both for the mother and for the infant. Then looking at things like other forms of diabetes that are genetically less common in pregnancy, how could we screen for those and eliminate those? So they've really contributed enormously to these observational real-world studies or randomized controlled trials of not having an IMP intervention. You're randomizing the process of care or the screening program that you're doing. And really the results of this program has been very instrumental in guiding national and international practice. And these women's contributions have made such a positive impact now to a new model of care that we are just about to launch with the Minister for Health for the care of pregnant women with diabetes in Ireland. So if we look then at international participation in the area of diabetes and pregnancy, the women in Ireland have contributed to 4 big trials. The DALI trial was looking at vitamin D and lifestyle intervention in gestational diabetes. The CONCEPT trial was looking at using continuous glucose monitoring in pregnant women with type 1 diabetes. And then the EVOLVE and the EXPECT trial were looking at new analog insulins for their use and superiority in pregnancy outcomes in women with diabetes. And because of the participation of women here in Ireland and other women globally, using CGM is now mandated almost for all pregnant women with type 1 diabetes because it improves outcomes so much. And the two insulins, Detamir and Degludec, which are new analog insulins, have now been licensed also for use in pregnancy. So the contributions of pregnant women make such important impacts on other pregnant women with the same condition who haven't been involved. So the HRB also have funded over the last 7 years 2 trials in Ireland that I think will have huge global impacts. The first is the Emerge trial, which was looking at a tablet called metformin, which is cheap and cheerful, available for 70 years. No pharma company is interested in it. Nobody's going to make money out of it. But actually, it may be effective and may have huge global impacts. And my colleague in the Rotunda, Fionnuala Brannock, has been looking at aspirin treatment in pregnant women to reduce the impact of diabetes on poor outcomes, including preeclampsia. So I think these 2 drugs, common drugs, could have huge impacts for the population of pregnant women with diabetes. So that takes me to the Emerge trial, which has been funded by HRB and is just completed and published. So the Emerge trial was looking at a tablet called metformin, that cheap and cheerful tablet available in every country in the world, to treat women with gestational diabetes. And the question was, well, why couldn't we use it, or why should we not use it? And I went back to look at the literature, and really there was a lot of uncertainty about the use of metformin from the information that was available in the literature, and that was based on 2 facts. One, there was a large clinical trial which was well powered, but it compared metformin with the usual treatment, which was insulin. So if you're comparing an injection with a tablet, number one, it's not blinded, and therefore bias can come into the interpretation of your data. And that large trial showed that metformin was actually useful, but it was associated with an earlier gestational age of delivery for the infants of the metformin group, which we don't want, and more cases of preterm birth, that's birth before 37 weeks, which we don't want. And then when I looked at all of the other trials, they were also comparators between metformin and insulin, and they were all small subject numbers, so really didn't have the power to answer the question that they started off with. So we decided that actually what was lacking was a large superiority, double-blind, placebo-controlled trial looking at metformin for the treatment of this condition. And that's what we did. We designed and developed and rolled out this trial. Now, I'm not taking you through the whole trial, but just to tell you that the trial did not show superiority for the primary outcome between metformin and the placebo groups. The primary outcome was a composite of, did the woman require insulin, and was her fasting sugar at week 32 or 38 greater than 5.1 millimoles per litre. But the trial did show very important impacts of the intervention, metformin intervention, on predefined secondary outcomes for the mother and the infant in terms of maternal glycemic control, maternal weight gain, and infant size. Participants who received the metformin were 25% less likely to require insulin. And if you're the woman with gestational diabetes and I'm the clinician asking you to inject 4 times a day, that is a really important fact. And then metformin was not associated with any increase in maternal or neonatal morbidities. And that's what the woman wants to know. Will I damage my baby? And metformin was not associated with early delivery or any increase in preterm birth. So we really did answer the questions that we set out. And I think this eases the clinical community and the patient population to maybe look at metformin. And this is important because 3 million deliveries per year are affected by gestational diabetes, and 3 million babies will be affected by that pregnancy. So that means there's 6 million individuals annually. And although we say insulin is a good treatment, and it is an excellent treatment, it has some drawbacks, but insulin is either not available or people can't afford it in many countries of the world. And the greatest burden of this disease is in the low and middle income countries. So I just want to take you through this slide, the consort diagram, just to show you the population and how we got to that point, and to bring out 2 points here. So between 2017 and 2022, 2,308 women were eligible in our location to participate in the trial. There were a lot of exclusions, but the main exclusion criteria was the fact that the women were outside the time window of 28 weeks to participate. And that makes me think again, why is there a delay? What is the delay between Mary getting diagnosed and Mary getting in to see me? So that's another clinical dilemma to answer. But about 400 women decided that they wouldn't participate in the trial, but that's only 17% of the total trial population, which was much lower than what I had anticipated. We also thought there would be a big kickback from partners of women going into the trial, but actually these women were quite well able to make their own decision, and this only influenced the participation of 8.6%. So we eventually had 535 ladies randomized. Half, 268, got randomized to the metformin arm, and the other half to the placebo arm. And 98% of the enrolled population stuck with the trial and were available for the primary outcome, which is really important. So losing pregnant women in a trial did not happen, and that's a very important take-home message. I wanted now to just bring you to the baseline characteristics, which is really also important for inclusion, as our previous speaker had shown. So in the west coast of Ireland, we don't have a huge ethnic population like you might have in the East Coast. So I would say at most it's 20%. In this trial, 80% of the women who participated were white Irish, as you can see, but 20% were other ethnicities, which is really important. And 20% is 107 patients of the trial population, which is a significant number. So it was important that we had all ethnicities available to us included. I was really also delighted to see that we included 13 traveller women who are an exclusion group, certainly in clinical trials in Ireland. All those women finished the trial and they were really good at taking their medication, so we had no problem there. How did we get this diversity of inclusion? So I think we had a few main things. We kept the consent process as simple as possible. We really focused on the patient information leaflet and made that as easy as possible for the women. We employed an interpreter service for all women who wanted to participate. And we gave women plenty of time when they were doing the consent process. So the average time to complete and sign the consent form was 32 minutes, but it ranged from 15 minutes to 90 minutes, and sometimes it was repeated. But that was fine. Now, when you looked again at the type of people we got into the trial, 80% had received or were receiving tertiary education, and that was because Galway was the centre for inclusion. But 20% had only achieved primary or secondary level education, which is important. 25% of the women had a medical card, so that would tell you that they are really in the lower socioeconomic group, and about 10% were unemployed women. So I think we had a really good diversity of inclusion. I'm delighted to tell you that this trial has been published in JAMA this October, and that's really good for the Irish community and for pregnant women. And already it's having a huge reach with 30,000 downloads of the article. So I think that, you know, what we put into this trial will reap rewards for patients with gestational diabetes globally. Now, of course, nothing is ever simple. So when we were doing the trial, it was a bad time because we got hit with COVID. We got hit with a cyber attack on the health system, which affects all of the ways that you're sending stuff to the labs and getting reports. And then we were no sooner out of that, and we had a cyber attack on the university, which affected the sponsor activities. And all of these really imposed on me dilemmas of, and the usual thing is, will we stop, will we go? Will we stop, will we go? And I mulled over the ethical dilemmas that I was faced with many times. And really for me, I had a knownness to the patient population that was recruited into the trial, which at that stage was about 250. So those women in good faith signed up the trial to answer a question, and I could only answer that question if I reached the trial numbers, which was 535. The second thing that was posed to me was, well, you know, if we recruit more women who into the trial, we're exposing them to COVID. But that was less of an issue to me because I thought, well, we can mitigate against these women not getting COVID. And then the cyber attacks came, and then it was all, you know, the integrity of the trial, and can we really rely on the integrity of the trial, and we overcome all of that. And while all of this was going on, of course, we had financial problems, so the money was running out. But despite everything and, you know, mulling it over and over, we did continue to keep going, found the money and completed the trial. Now, while we were doing the trial, we looked at two aspects. One was the perception of women going into the trial. So what is it that these women, what is it that makes these women go into a trial? So we wanted to just explore the decision making, and we did this in a qualitative descriptive design and really came up with these thematic areas. And there were three thematic areas: perceived benefits of participation, the whole recruitment process, and then these trial considerations. So the perceived benefits were really important to the women, so avoiding or delaying the onset of insulin, getting extra support from being in a clinical trial, potential benefit to the baby, and altruism came out really strongly. So although a lot of them admitted, well, I mightn't get any benefit, going forward other women might. Now, the recruitment process for the trial also influenced their participation. So they liked the fact that the PI was involved in clinical care as well as research. The team, they felt, were knowledgeable and trustworthy. They liked the personal interactions. They liked having written and verbal consent or communication, lots of time, and they liked the voluntary nature of participation. The things that I hadn't considered that would influence their participation were parts of the trial. So they acknowledged that it was important to have a placebo-controlled trial to answer the question. They understood the process of blinding and felt that blinding was actually a very good thing because everybody was getting treated similarly. And then the fact that randomization was important to answer the question was also there. Now, those that declined participation are people who do not perceive any personal benefits from participation, or they were women who thought that they would manage on just dietary intervention alone, although that will only work in 40%. They didn't think they'd require any medications. They had a greater perception of risk also. So overall, women viewed participation very positively. Altruism was very important. Women viewed aspects of trial design, including randomization, use of placebo, blinding, voluntary decision to participate, and withdrawal if you required it, very positively. Orderly trial administration was perceived as something that was really important to these busy women who want to participate in the trial, but they have no time for messing around and delaying time. And trusting clinicians and the clinical team came across very strongly. So thank you very much for listening, and I'm happy to